Good afternoon, everyone, and happy Lupus Awareness Month. I'm delighted to welcome you to today's webinar, From Bench to Bedside, CAR T-Cell Therapy Innovations in Lupus Care, presented in celebration of Lupus Awareness Month. My name is Allison Peisner, and I'm the manager of the Lupus and APS Center of Excellence at Hospital for Special Surgery, also known as HSS. Today, I'm excited to partner with the Department of Social Work in honor of Lupus Awareness Month and welcome you all to this important presentation. Today, I am accompanied by my esteemed colleague, Priscilla Calvache, the Director for the Department of Social Work Programs at HSS. Priscilla will be joining us later to facilitate the question and answer portion of the webinar following the presentation. Before we begin, just a few housekeeping notes. Participants will remain muted during the webinar, but we encourage you to use the chat icon to submit your questions at any time. Finally, we truly value your feedback, and at the end of today's session, we ask that you take a moment to complete our brief evaluation survey. The link will be also posted in the chat box. And now it is my pleasure to introduce our speakers for this afternoon in the order in which they will be presenting. Dr. Samuel Yamshon is an assistant professor of medicine at Weill Cornell Medicine and New York Presbyterian Hospital and the director of the Cellular Therapy Service. Dr. Yamshon cares for patients with lymphoma with a focus on improving the efficacy of immunotherapy, including bispecific antibodies and CAR T-cell therapy. He is the founding director of the Cornell Lymphoma Meta-Analysis Working Group and the Cornell Cellular Therapy Biobank, and works closely with the laboratory collaborators to develop novel strategies to prevent T-cell exhaustion and modify the tumor microenvironment, bringing these treatments from the bench to the bedside. Dr. Kyriakos Kirou is a physician scientist and rheumatologist specializing in the care of patients with systemic lupus or SLE, and he is a director of the Lupus Nephritis Program and the director of the Lupus Interventional Clinical Trials Program at HSS, and the co-chief of HSS's Lupus Clinic. He is an assistant professor of clinical medicine at Weill Cornell Medical College. Leila Khalili is a nurse practitioner at the Columbia Lupus Center. She divides her time between the care of patients living with SLE and clinical research. Leila started her career in lupus as a clinical research coordinator at HSS, working on phase 2 and phase 3 lupus clinical trials. After graduating nursing school, she joined the Columbia University Lupus Center as the recipient of the Rheumatology Research Foundation Mentored Nurse Practitioner Award, which allowed her to further develop her rheumatology and research skills. She serves as the Director of Research Operations at the Lupus Center and is an investigator on several therapeutic and observational lupus studies. Her main interests include SLE and patient education, the role of telemedicine in SLE care, and therapeutic and new drug development in SLE. Please join me in giving a warm welcome to our speakers. Dr. Yamshon will now begin.
Thank you so much for the introduction, Allison, and thank you everyone for being here. It's really a pleasure to speak with you tonight. Again, I am Sam Yamshon, and I direct the cellular therapy program here at Weill Cornell Medicine, where I'm a medical oncologist, but I'm very excited to share with you a little bit about kind of the history of CAR T cells and why we're so excited to expand this beyond oncology and bring it to patients with lupus and beyond. Next slide, please. So these are my disclosures. Next slide, please. So just a brief list of some of the topics that we're going to talk about tonight. I'm going to share a little bit about the history of CAR T cells, how they work, and some of the ways that they have just been incredibly effective in treating cancer. Talk a little bit about some of the side effects of CAR T and why they need to be given at specialized centers, and then talk a little bit about the future of CAR T and other immunotherapy in cancer and in lupus as well. Next slide, please. So what are CAR T cells? Next slide, please. So I think the key to understanding what CAR T cells are is understanding the fact that our immune system under normal circumstances actually is able to target misbehaving cells. So that can be invaders, so that can be bacteria, viruses, and fungi, but that can also be bad actors in our own body, like abnormal B cells in autoimmune disease or cancer cells. But in order for our immune system to recognize those misbehaving cells, those cells actually typically, for the T cells to be able to see them, need to recognize this flag. And over here on the left, you have the T cell receptor, which actually has to recognize this protein, HLA, on the surface of these cells. And if that protein isn't there, or if there are other ways for the cell to shut down the T cell seeing it, then the T cell isn't actually able to target the right spot and therefore isn't able to attack the misbehaving cell. And so the innovation of chimeric antigen receptors, and this is the image over here on the right, is that we're able to actually bypass that HLA protein and able to allow the T cells to recognize those misbehaving cells and target a specific spot on the surface that allows us to target the bad guys while leaving all the good guys alone. Next slide, please. And so as it turns out, just allowing the T cells to target the new cells is not enough. And so originally they started putting this protein on the surface that allowed them to target, but the T cells still didn't do much. And so it turns out that they needed to add on a co-stimulatory domain, which is essentially a protein that acts as a gas pedal that allows the T cells to activate and really go into attack mode against these bad guys. Next slide, please. So how do CAR T cells actually work? So the delivery of CAR T cells is a multi-step process, and Leila later on in this talk is going to go into a little bit more detail about some of the logistics of this. But essentially what we do is we actually take people's immune systems out of some cells from their immune system, the T cells, out of their body, and we reprogram the cells and basically turn them into the special forces to fight against whatever bad guy we decide, be it cancer or be it an autoimmune disease. And so the first step is actually to take some of those immune system cells out of the blood. Usually people come into our office, they get either an IV in each arm or a special IV in the neck. Blood comes out, we take out the T cells, and then we return the rest of the blood. And so people aren't actually losing blood, we're just able to take out the T cells through a filter. And then we send the cells off for manufacturing. And when I'm talking with patients, I sometimes refer to this step as boot camp. And while the cells are at boot camp, they undergo genetic engineering using a viral vector to insert this chimeric antigen receptor protein onto the surface. And then we expand them to basically create an army that's going to come back and attack all of those misbehaving cells that we want to target. And so then we get a call from the company that the cells are ready. Currently in CAR T therapy, we give a very light dose of chemotherapy before the cells are returned to the body. And the reason for that is actually to make room for the new cells to come in, not actually to do anything against cancer or the autoimmune disease. And then the cells are introduced into the bloodstream via either an IV bag or a syringe. And then once the cells hit the bloodstream, they're part of patient's own immune system. And so they are in the body and they are fighting, and they basically start being active as soon as they hit the bloodstream, and they are alive and ready to fight. Next slide, please. So CAR T, as I mentioned earlier, my research focus is in lymphoma, and CAR T cells have really represented a pretty dramatic paradigm shift for patients with lymphoma. Next slide, please. So just very briefly, and I know that this isn't the topic of tonight's discussion, but I think kind of drives home just how effective CAR T cells are in other diseases. So patients with diffuse large B-cell lymphoma, which is the most common kind of lymphoma, for patients who the disease is not cured with chemotherapy, which is about 1/3 of patients, the outcomes after the lymphoma comes back has historically been poor. And typically the next treatment has traditionally been an autologous stem cell transplant. But if that treatment didn't work, typically patients would eventually, unfortunately, succumb to their disease. But that was before we had CAR T cells. Next slide, please. And so CAR T cells have really changed the game in lymphoma as well as other types of blood cancer. Currently, there are 3 different CAR T cells that are approved in lymphoma. They all target that same spot on the surface of the lymphoma cells, and it's actually the same spot CD19 that's targeted in treatments for lupus. The CAR T cell products differ very slightly in their manufacturing, including which type of gas pedal protein that they use. Next slide, please. And so several of these constructs have been tried actually as now the second treatment for lymphoma. So even basically trying to replace stem cell transplants. And as you can see from these curves here, these were clinical trials where patients were basically had a 50-50 shot. They were randomized to receive either CAR T cells or the old standard therapy. And basically CAR T had a very, very, very dramatic effect, a dramatic improvement over the standard therapy in terms of keeping the lymphoma away. And in many of these cases, whereas many of these patients would previously have eventually succumbed to their disease, are now cured with CAR T cells. Next slide, please. And importantly, at least with one of the CAR T constructs, clinical trials have actually shown that patients are not only cured of their cancer, but that they actually do live longer with the CAR T cell therapy, mostly owing to the curing of the disease, but also owing to the reduced toxicity and side effects relative to stem cell transplants. Next slide, please. So with the success of CAR T cells in lymphoma, there's been a real explosion of CAR T cells now in use across numerous blood cancers, now with multiple targets. And so this is a very busy slide, but I think it just goes to show these are all the current FDA-approved CAR T cell therapies in many, many different types of blood cancer. And these ones in yellow, in that yellow font, are actually ones that have been approved in the last 12 months. And so this is a very rapidly evolving field, but I think, as shown by this slide, one where things are improving quite quickly and things are moving quickly because these treatments are so effective. Next slide, please. And so CAR T cells have been studied with the same target as lymphoma. So it's actually the exact same CAR T cell with the exact same construct that we use in lymphoma, but they've actually shown efficacy in autoimmune disease. And so this is just one graphic of several figures from a paper, of which now several have been published, using CAR T cells in autoimmune disease. Over here on the left part of the image is in 8 patients in lupus. And as you can see here, there's been a very, very, very dramatic improvement. This score over here, the SLEDI 2K score is a clinical score, and I know Dr. Kirou will be talking a little bit more about some of the measures of response in lupus. But as you can see here from these figures on the left, there's been a pretty dramatic improvement in patients with lupus after they receive these CD19 CAR Ts. And figures C and D are actually for beyond lupus. And so figure C is inflammatory myositis, and figure D is systemic scleroderma. And so this really is showing a lot of promise in autoimmune disease, which is, in B-cell driven autoimmune diseases. And so is an area of a lot of excitement. There's also CAR Ts now being studied in multiple sclerosis. So really just a dramatic expansion of the way that we use these medicines. Next slide, please. So one thing that I think is important to know is that CAR T cells do have some unique toxicities. Next slide, please. So the way that I understand and kind of wrap my head around the side effects of CAR T is that, I had mentioned at the beginning that our immune system, under normal circumstances, fights off many different kinds of invaders, and that includes infections. And so really at its core, the CAR T cells are treating these abnormal B cells, be them lymphoma or be them abnormal B cells in lupus. They're treating them like invaders. And so many of the side effects of CAR T are very, very similar to side effects that you might get if you got a bad infection. And so many of the symptoms of CAR T are related to that immune response. So one of the more common side effects that we see with CAR T is something called cytokine release syndrome, which is a fancy way of saying, the immune response to an invader. And again, many of those manifestations are like having an infection, like having a bad flu. So for example, fever is quite common. That fever can be high, 102, 103-degree fever. And sometimes that fever, just like when you get the flu, can be associated with other symptoms, cough, shortness of breath, racing heartbeat, low blood pressure. And so we generally do monitor people who are getting these therapies in the first couple of weeks when these symptoms are potentially at their peak very closely, and kind of give anti-inflammatory drugs to help calm down the immune system. Rarely, these symptoms can be severe enough that sometimes patients do need to be potentially admitted to the hospital, or even potentially need additional therapy to keep their blood pressure up. But these days, thankfully, we've gotten very good at managing these toxicities, and just generally with some of the anti-inflammatory drugs are able to keep many of these side effects at bay. The other, in the short term, other kind of disconcerting toxicity or side effect that can sometimes happen is just like when people get a severe flu, they can sometimes get delirious. And so, and that can happen with CAR T cells too. And that is referred to as neurotoxicity. Generally speaking, it's actually the minority of patients who get neurotoxicity. In some of the studies of the newer CAR Ts, less than 15% of people get any degree of neurotoxicity. And usually when it does happen, it's pretty mild. We actually give people a quiz when they're getting treatment. If they're in the hospital, we actually give them a quiz every 8 hours or so. And if we start to see that they're missing questions, we intervene again with anti-inflammatory drugs like steroids. On very rare occasions, those side effects can be more severe. People can get confused and forget what day it is. On very rare occasions, can sometimes even forget how to speak. And in the very early days of CAR T, we did see rarely seizures. And these days, we're actually giving anti-seizure medications ahead of getting the CAR T. And since then, we basically haven't seen that side effect at all. And so these side effects can be scary, but I think, number one, are the severe side effects are uncommon. And number two, at a center that does a lot of CAR T cell therapies, we are able to recognize and intervene on these toxicities early, and in many cases actually give anti-inflammatory drugs ahead of time to even prevent them from occurring in the first place. Next slide, please. So those side effects, the fever and the potential confusion, if they happen, generally happen in the first 2 weeks after CAR T cells, and certainly before the first 30 days. And so usually by the time, the first couple of weeks after CAR T, you're out of the woods from that front. But there is, as you can imagine, an increased risk of infection, just like with any other treatment for an autoimmune disease, because you're lowering the immune system. There is an increase of infection even months after treatment. For many patients, their immune system does return back to normal within a few months, but there are some patients who, several months later, or even years later, do still have low B cell counts, low levels of antibodies, which we're able to supplement. We do generally give people vaccinations again after the CAR T, because the CAR T does in some ways reset the immune system. Next slide, please. Another thing that I think is important that can sometimes happen, and this is a complicated slide, but essentially suffice it to say that there are low blood counts can occur after CAR T cells, and there are many different reasons that those low blood counts can occur. Usually, most counts are back to normal within 30 days. A minority, it takes a few months, and I do have about 5% of patients who have low blood counts even a couple of years later, and we're happy because their lymphoma is gone, and we're kind of willing to live with a little bit of low blood counts. But we generally do kind of try to figure out why those blood counts are happening, because in many cases we're actually able to intervene and fix it. Next slide, please. So as I mentioned, CAR T must be given in a specialized center, and that is an FDA requirement. And patients in particular must be within 1 to 2 hours of the CAR T center for 30 days. And the FDA label actually says no driving for 8 weeks, even though we know that neurotoxicity is extremely unlikely to recur after those first 14 days. That is an FDA requirement. I also just think, regardless, these short-term side effects, as I mentioned, I think do require some expertise, including the needing to have some of those anti-inflammatory drugs on hand, ready to use, which a non-specialized center just doesn't have access to. And long-term, patients don't necessarily need to, continue to come back to the CAR T center, but generally speaking, I would say that I co-manage with patients, local doctors, to try to, make sure that some of these long-term side effects can be managed if needed. Next slide, please. So I know I'm almost at time, but I do want to talk a little bit about the future of immunotherapy in both cancer and autoimmune disease. Next slide, please. So these are some of the new treatments that are in the pipeline that may change the future of treatment, both for cancer and for lupus and autoimmune disease. And so these are things that are, I think, potentially coming in the next few years. One that is already in trials is a CAR T that targets a different spot on abnormal cells called BCMA, that some people think may be more effective in lupus even than targeting the current target of CD19. Obviously, that would be great. There are some potential rare neurologic side effects that we see because that treatment's already in use in multiple myeloma. And so I'm going to explain what GVHD means in a second. With regards to the allogeneic CAR T, so allogeneic means a CAR T that's actually not taken from yourself, but that's taken from a healthy donor. And so those CAR Ts, the advantage of that is that since you're using a healthy donor that you don't know, you can actually have those cells available essentially immediately. And that allows for fitter and healthy T cells. But it requires additional manufacturing of those allogeneic products, because when you're getting a product from another person, there's always the risk that those new cells recognize you as the invader, and so they start attacking you. And so that is called graft versus host disease, or GVHD. Another potential strategy is using a different part of the immune system called natural killer CAR cells. And those are also potentially available off the shelf. And just by the nature of how those cells work, there is a lower risk that those cells will attack you, that GVHD risk. But those are still in early trials, and thus far the efficacy is unknown. And so I think, it remains to be seen whether that's another potential strategy. And then lastly, another treatment that is already in use in cancer and is, I think, potentially exciting for autoimmune disease is something called bispecific antibodies. And the way that those work is they're antibodies kind of like rituximab that many of you probably know, but the difference is that it has two ends on it. One end links up to the abnormal cells, the B cells, and then the other end links up to the T cells, and it essentially brings them together to allow those T cells to see the abnormal cells. And so the way that I describe it to patients is it's actually turning all of the T cells in the body into CAR Ts. And so there's a lot of advantages to that. It's available off the shelf. There's no chemotherapy portion, and the rates of toxicity are lower than with CAR T cells. But the con is that once those antibodies are out of the system, then the T cells kind of, it's almost like, Cinderella, at the stroke of midnight, they kind of turn back into normal T cells. And so you need to continue giving the bispecific antibodies every few weeks in order to continue having efficacy. Whereas CAR T cells are in the body and continue, are alive and continue to fight over time. Next slide, please. So that's pretty much what I have for this evening. I'm excited to pass it over to Dr. Kirou, and I'm going to stay on for Q&A at the end. And I'm also going to share my email in the chat. And so anyone who wants to reach out directly with questions, don't want to ask in public or whatnot, please feel free to reach out anytime. And thank you all for having me.
So, hi, everyone. It's a pleasure to be with all of you celebrating Lupus Month and sharing with you this important information about this exciting therapy that is coming to autoimmune diseases and especially lupus. Next slide, please. This is the disclosure. So we're currently going to start a CAR-T trial, and we're working with New York Presbyterian, Dr. Yamshon as well. Next slide. Next slide, please. Yes. So very quickly, I'm going to discuss useful facts about lupus. You probably already know all of this. Lupus is a disease of young or middle-aged women. Much more females than males are affected. Perhaps the disease is more common in African Americans, Hispanics, Asians, and it may be more severe in some occasions in those populations. Lupus nephritis is probably the most severe and more frequent severe manifestation of lupus in about up to 30 to 50% sometimes of patients, and usually happens early on, and that's one of the manifestations of lupus that we want to target with this new approach. Next slide. So Dr. Yamshon already talked about the immune system a little bit, and just to reiterate that part of the immune system is the adaptive immunity, and that's very sophisticated, target-specific antigens in the body. And in the case of obviously foreign organisms, it targets to kill them or kill tumor cells. So the two important parts of that is lymphocytes, cellular immunity with T lymphocytes and B lymphocytes. T lymphocytes is what we heard just before. We can, in this situation, we try to use them to make them as a living weapon against autoimmunity. And they have the ability, because they have the ability to kill foreign cells or other cells that are there and cause harm. B lymphocytes, on the other hand, they don't directly kill, but they produce antibodies. And these antibodies are proteins in the blood that stick to antigens and then help eliminate foreign organisms, for example. Next slide, please. So again, lupus is an autoimmune disease. The immune system is now dysfunctional, and in addition to fighting infections, it targets now the self. So and that we call autoimmunity. So what causes lupus and autoimmunity is multifactorial. There are things like genetics, mutations or variations in certain genes that are common otherwise in the population. Certain infections may trigger things. UV light, drugs can also trigger things. So it has to do with a combination of factors that can lead to lupus. So antibodies that target self-antigens are called autoantibodies, and you already know the ANAs, the antinuclear antibodies, the antibodies against double-stranded DNA, the Smith, the RNP, the Sjögren Rho antibodies, and so on. So the antibodies, the autoantibodies, when they bind to their target, they form immune complexes, they deposit to tissues and cause inflammation. Inflammation in the joint is called arthritis, in the kidney, nephritis, etc. Next slides, please. So what do we do to treat lupus now? We use general immunosuppression with steroids, with hydroxychloroquine, which is an anti-malarial drug, other immunosuppressive drugs such as methotrexate, azathioprine, mycophenolate, tacrolimus, and so on. And sometimes we use chemotherapy for the very severe patients. More recently, we have been lucky to have some additional drugs that are very helpful. They're called biologics, and they are made more specific to targets. So, for example, anifrolumab is a monoclonal antibody that blocks interferon. Interferon is very important in lupus. Another drug that you may be familiar, you probably are familiar, is belimumab, which also blocks activation of B cells. And then we have some other cells, other drugs that target and not only block activation, but actually kill B cells, and that's rituximab. And there's a new one that is hopefully will be approved also by the FDA soon, obinutuzumab. Next slide, please. So unfortunately, despite all these drugs, we still are not there. We cannot cure lupus, and we cannot prevent organ damage in certain patients that have more severe disease, especially. What causes drug failure? So when we talk about clinical trials, poor design of trials has been an issue in the past, but in reality, we cannot cure lupus or prevent organ damage because some of these drugs, although they may be effective to some degree, they cause many side effects, and we have to back off. The effects they have are not lasting if you stop the drug, so you have to keep taking those drugs. And they don't, in the case of rituximab or B-cell depleting agents, they don't deplete enough the B cells, and those autoimmune cells stay there. And you take the drug, they're still there, and they can still cause damage. The existing drugs also have many side effects, and we already know about steroids, how bad they are for weight gain, diabetes, high blood pressure, osteoporosis, and so on. Other drugs, like methotrexate or mycophenolate, cause nausea, diarrhea, low counts, infection, and rituximab can cause infusion reactions. Next slide, please. So this is a slide that tells you about the LUNAL trial. The LUNAL trial took patients with lupus nephritis, and they gave them either mycophenolate with placebo or mycophenolate with rituximab. As you can see on this panel, the black bars are those people who received rituximab and mycophenolate. The other ones that had the placebo and the mycophenolate. There was no difference between the two. There were no statistical significance. If anything, it was worse with rituximab. Yet we know that this drug works. I don't have the right panel. Can we go to the next slide, please, in case we can see it? No. I guess what I wanted to show, go back one slide. What I wanted to show is that if you select patients that had complete depletion of B cells, so for some reason the rituximab did a better job to deplete all the B cells, then those people fared better in the end. So that was so that tells you that it's important to achieve better depletion of B cells. Next slide, please. So here is all the B cells from the time they start in the bone marrow all the way out to the periphery, the circulation. They go through several stages, and we can kind of tell the stages by what receptors they have on top of them. So CD20 with red starts from here and goes all the way to the peripheral blood. And this is the target for Rituxan. So it covers a lot of them, but it doesn't cover plasmablasts. Plasmablasts are the activated B cells that are now producing antibodies. So this is a key cell that we need to target in lupus to fight better autoimmunity. It also doesn't target plasma cells. So some of the activated cells will become plasmablasts, some other will become memory cells, and some of them also will become plasma cells, and these live for a long time in the bone marrow. So for lupus, for some reason, the bad effectors, the bad antibodies, mostly come from plasmablasts. So if we target those, we do a good job. So the people argue, though, that we should also target those other plasma cells. And to do that, we have to use this BCMA that Dr. Yamshon mentioned before. So I guess those are things that will pan out in the future as we see the results of the studies. Next slide, please. So CD19 CAR T cell therapy in lupus depletes all the B cells, so not like Rituxan, but it does a better job, eliminates also the plasmablasts, and therefore eliminates DNA antibodies and Smith and so on antibodies. The plasma cells who secrete good antibodies, for example, antibodies to tetanus, you got your vaccine when you were young, you still want to have protection against an infection, so those stay there. They're not deplete, or maybe they were deplete. They will go down a little bit only. And then what happens is, after you kill all the B cells, some of the B cells come back, and they come back in a few months. And those that come back are naive cells. They are not anymore autoimmune cells. They are good cells, And we call this immune reset. So we heard this term a little bit earlier. So it means that we try to make the immune system new again without the bad autoimmune B cells there. Adverse effects, you already saw some of them, the CRS, the cytokine release syndrome, and the neurologic syndrome. Those happen less in lupus because the T cells, the CAR T cells target only a few cells as opposed to lymphoma, where in lymphoma, the CD19 cells are so many of them, and therefore you get a very high activation of the CAR T cells, and therefore you have more side effects, more cytokines. So in autoimmunity, we don't expect so many side effects from this mechanism. Next slide, please. Okay, so this is already shown in some way by Dr. Yamshon, but let me tell you, this is a New England Journal of Medicine article from Germany, Dr. George Seth, who has been a pioneer in autoimmune disease with CAR T cell therapy. In this case, they had 15 patients. Can we see the next slide, please? And here you already know now that there were 8 lupus patients, 3 myositis patients, and 4 patients with scleroderma. We're going to focus on the lupus patient. They were mostly young, between 18 and 35. They had nephritis, all of them, and skin disease was very common. They were all on steroids, hydroxychloroquine, mycophenolate. Many of them received rituximab. You see 4 of them had already received rituximab and belimumab. All of them received belimumab. So these are patients that failed at least 2 other therapies that we use for lupus now. Next slide, please. So now we can see again that after they receive the CAR T treatment, they receive remission. And remission is not something we talk about often in lupus. We don't see remission often. So this is very new and very encouraging. So all of these people had remission of the disease without medication. They were able to go off mycophenolate, steroids, hydroxychloroquine. And the SLEDAI score, which measures disease activity, it's a composite score looking for joints, skin, kidneys, all together. It came back to 0 now. And they were glucocorticoid-free, no steroid, and no immunosuppressive drugs. So this Dr. Yamshon already showed you this slide. The SLEDAI activity score is down. The DNA antibodies are down. The C3, which indicates activation of the immune system, from low, which is abnormal, went to normal levels. And the protein in the urine also went down. So this is very difficult to achieve in lupus nephritis, to eliminate protein. It takes many months. So in this case, it happened very quickly, within a few months. There was one patient that had a spike of protein, but then this patient had a biopsy, and it was shown that it wasn't really the type of lupus nephritis that we worry, and everything came back to normal very quickly. Next slide, please. Again, this is showing all the antibodies going down below the threshold. Some antibodies, like the Sjogren 60, Rho 60, remain high despite the treatment. So it's not a perfect thing for everything, for all the antibodies. Next slide, please. So here we see that what happens after we do the CAR T therapy. The naive, the good cells, they were low, and then now they come back and they are normal now. And these are the bad actors, the plasmablasts that they go down and remain down. So next slide, please. So just in more schematic way, here is what happens after you do the CAR T therapy. These are the CAR T cells. You infuse them in the person, and here when they get them, these are the B cells. From being high, they go down to 0. And then eventually, after, in this case, 2 months or 3 months, they start going up. Now these B cells go back up, and they are ready to protect you from infections and help you fight and help you respond to vaccinations. And these are the good B cells in this situation. The CAR T cells, they go very quickly up in order to do their job and eliminate the bad B cells and all the B cells actually to cause the immune reset. And then eventually they go away and they disappear. We cannot detect them after that. This is the DNA we already saw. The antibodies went down, the proteinuria goes down, and the activity goes down. Next slide, please. Safety, I just want to show briefly that there were very few patients with cytokine release syndrome. And actually, I wanted to say the grade was low. So grade 1 is minimal. They don't need any treatment. Grade 2, one patient had grade 2 with myositis, and these people may receive steroids. Again, some patients, like 1, 2, 3, 4 patients here received something called tocilizumab because they had higher fever. So that's how we treated. It wasn't very impressive. Everybody did well in the end. Next slide, please. So again, in summary, low-grade cytokine release syndrome, low-grade the neurotoxicity syndrome. We have started to see some other local immune effector toxicity syndrome effects. So people who had skin rash because of lupus, after the treatment, they get a flare of the rash, but it was very it subsided very quickly after several days without doing anything, or in some cases they received a little steroid and it went away. So this was not lupus, it was just the effect of being the effect of CAR T cells eliminating those B cells in the skin. And then because they do that, there is some inflammation that happens in the skin and you see the rash. But then the rash goes away because then there's no reason to be there anymore. So this will be primarily skin. It was also transient kidney proteinuria, like we saw in that patient. Everything resolved. Infections were they were very mild, particularly upper respiratory. However, they have 2 cases of shingles in this paper, pneumonia and cellulitis, 1 patient. So overall, very well tolerated in this population. Next slide. So who are the potentially eligible patients? As you saw, all these people were young, so we try to get people who are relatively, at this phase of research, we want to have people who don't have severe damage or failure of organs. For example, severe heart disease or severe kidney disease will not get in the study. So they have to have lupus. They have to be more than 18. I think in some situations, some studies allow patients above 16. They have to be active disease. We don't want to have people who have only damage but not activity, because we're not going to be able to show the improvement. And they have to have failed to respond to steroids and at least 2 of the following agents, the chemotherapy agent, the mycophenolate, rituximab, anifrolumab, all of those. And contraindication, we already mentioned life-threatening end organ damage like heart failure, lung failure, liver, and so on. Next slide. So Dr. Yamshon already mentioned alternatives that we're going to see those in the future. I think for now, we want to see how the traditional CAR T works. Next slide. And this is our interventional clinical trials program at HSS. Thank you very much for your attention. And I give now the baton to Leila Khalili. Thank you.
Thank you, Dr. Kirou. Hi, everyone. It's a pleasure to be with you all today for Lupus Awareness Month. Today, I'm going to give you a general overview, walking you all through what happens over the course of CAR T therapy. Next slide, please. Dr. Kirou and Dr. Yamshon already touched on this, but CAR T is a multi-step process. It broadly involves isolating your own T cells, which are part of your immune system. These cells are reprogrammed with a virus to target lupus antibody-making cells and given back to patients. Dr. Kirou already reviewed the very promising preliminary data in lupus, and there are now multiple clinical trials which continue to test CAR T in lupus patients in larger numbers. Next slide, please. This is a broad overview of what protocols for CAR T therapy look like, and I'll talk more in detail about each step. I think it's important to note that throughout this entire process, rheumatologists and oncologists work side by side, but for some parts, primarily the rheumatologist is in charge, and for other parts, primarily the oncologist is in charge of patient care. The process starts with informed consent and screening to check for patient eligibility. Once the patient is deemed eligible, they undergo leukapheresis, which is the process of isolating immune cells that are then shipped out for manufacturing at a specialized facility. Once the CAR T cells are ready, they'll be shipped back to the hospital, and the patient undergoes lymphodepletion chemotherapy in preparation for receiving the CAR T cells. Patients are then admitted to the hospital for the CAR T infusion, where they stay for at least a couple days for very close monitoring. And if there are no complications, patients are discharged, where they follow up with the oncologist and rheumatologist outpatient frequently. Next slide, please. The whole process of any clinical trial starts with an informed consent and a screening visit. Informed consent is a detailed discussion with your doctor that includes what to expect during the study and what potential risks and benefits are of consideration. In this case, the discussion happens to be with your rheumatologist, but also your oncologist. The informed consent for CAR T typically includes a discussion of alternative treatments, including current standard of care therapy, as well as cell therapy side effects, specific monitoring for CAR T therapy, and the potential benefits and risks of CAR T therapy, including CRS, ICANS, and infections like Dr. Kirou and Dr. Yamshon talked about. Next slide, please. The screening visits include multiple tests that vary based on patients and protocols. Some of these tests are blood tests, an EKG, a sonogram of the heart, a chest x-ray or CT scan to look at lungs, and possibly a kidney biopsy. Other appointments that are necessary include oncology appointments and possibly nephrology appointments, depending on the patient. Because there are so many tests, eligibility may take up to a couple weeks to confirm. Additionally, during this time, your doctor will likely start the process of washing out lupus medications to improve the quality of the T cells that will eventually get shipped out for manufacturing. Next slide, please. Leukapheresis is the process by which T cells are isolated so they can be prepped and sent for manufacturing. It's a procedure that removes the white blood cells via a machine. You may need a temporary line put in place for the procedure, depending on your venous access. It takes a couple of hours. Cells are sent for manufacturing at the completion. Once leukapheresis is completed, the doctor may start bridging therapy, which means restarting immunosuppression or adding steroids to treat lupus until the next step, which is lymphodepletion. Next slide, please. Lymphodepletion is the administration of chemotherapy, which is fludarabine and cyclophosphamide. The purpose of chemotherapy is to eliminate immune cells that may interfere with the CAR T and to make space for the CAR T cells like Dr. Yamshon talked about. The medications are administered a couple days before the CAR T and can happen inpatient or outpatient. One of the important things your doctor may talk to you about at this time is fertility, which these medications may affect, and your doctor might refer you to a fertility specialist for more information. Next slide, please. The next step is the actual administration of CAR T. Usually patients are admitted the day of or the day before, and you might get pre-medication like Benadryl beforehand. Many hospital protocols will also include things like antibiotics for infection prophylaxis. The CAR Ts are administered intravenously through a peripheral line placed in your arms to help with both the administration of the cells, but also to make blood draw easier over the next couple of days during the hospitalization. After the CAR T is administered, you'll get frequent vital signs and blood work to monitor for side effects, again, primarily CRS or ICANS and infections. During this time, patients are watched very closely, and if side effects develop, further tests and treatments may be necessary, which can prolong the hospitalization. Next slide, please. After the inpatient monitoring period, patients are discharged with frequent outpatient appointments and blood work with rheumatology and oncology over the first couple of weeks. Oncology continues to monitor for the side effects of CAR T, and rheumatology continues to monitor for lupus disease activity. After the first couple of weeks, rheumatology continues to monitor regularly, usually on a monthly basis, for disease activity, for at least a couple months, and then a follow-up is required at least once a year for 15 years. Next slide, please. Some other things to consider for CAR T therapy, and we talked a little bit about this before, include social supports during this time. An oncologist will recommend avoiding driving. Many protocols require a caregiver after discharge. Additionally, protocols usually require staying in close proximity to the medical center over the first couple of weeks, which is an FDA requirement. Some studies will cover the cost of travel and hotels. Time off work. Many patients will require time from work for the inpatient hospitalization and frequent follow-ups, as well as social distancing for the first couple of months to avoid infections, if that's something the oncologist recommends. Some patients may require short-term disability or FMLA paperwork to help with this. Next slide, please. So in summary, CAR T therapy for patients with autoimmune diseases offers the potential of a drug-free remission. However, monitoring for sustained remission is still ongoing. Most side effects that we know of so far have been mild and responded to treatment, but safety data is still being collected, and long-term monitoring is needed for side effects, including infectious complications and possibly other complications. More data is needed before CAR T is standard of care for lupus. Additionally, CAR T is expensive, and this is something to consider if it becomes standard of care. We're still learning a lot about other cell therapies other than autologous CAR T, including off-the-shelf CAR T and other types of CARs, and new therapies like T-cell engagers, like Dr. Yamshon had discussed. This is a steep learning curve for all, but it's also an exciting time in lupus and autoimmune diseases. I know we're all looking forward to seeing more data over the next couple of months. And I think with that, we'll take questions.
Thank you so much to our excellent panel of speakers. We're so excited to jump into the question and answer portion of our program. Just a reminder to please submit your questions using the chat box feature. We're going to begin with some of the questions that came in during registration, and we'll also be monitoring the chat box to get to as many of your live questions as we can, but also to help us cover as many as possible of the submitted questions. They've been grouped by theme, and this will help us to address as many questions as we can during the session. And again, we'll focus on the most relevant topics and aim to provide some useful takeaways. So to jump in with our first question, what is the end goal with CAR T cell therapy? Is an indefinite remission, a potential cure, or something else?
I guess I'll take this question. Yes, so I guess the first studies show drug-free remission, which is very encouraging. But again, they go up to 2 or 3 years so far, and we haven't had data for more than that. So we have to wait to see how this evolves. It is potentially possible that the lupus may come back because some of the antibodies haven't completely gone away, and it's possible they can trigger something down the line. So we don't know, but for now, we know that people were able to go off medication and stay well for at least several months, and a couple of them for 1 to 2 to 3 years.
Thank you, Dr. Kirou. And just to add to that, either for Dr. Yamshon or Dr. Kirou, would it also cure APS? So, for example, would we no longer need blood thinners?
That's an unknown because we haven't seen data about APS, but as far as I can tell, I'm not aware of data that people with APS were treated and then the antibodies went away and they didn't need to be on blood thinners. So we have to see more about that. We cannot talk about APS.
Thank you. So what happens to the immunoglobulin in lupus patients?
I think in lupus and probably oncology patients, the immunoglobulins go down, and this may lead to infections down the line. Sometimes we give IVIG gamma globulin to patients to replete the stores of antibodies. And Dr. Yamshon mentioned that we need to vaccinate some patients because they need to increase the vaccine titers.
I would agree with that, and pretty consistently with CAR T cells. I mean, CAR T is so effective at getting rid of the bad B cells, but also gets rid of a lot of the good B cells, and so the antibodies can stay low for quite a while, and we, especially at the beginning, relatively frequently supplement with IVIG.
Thank you. This question can go for anyone on the panel or all of you. What if any concerns do you each have for CAR T use in autoimmune patients?
I guess when you talk about cancer, I guess everything is scary. You want to do the best you can. But in autoimmune disease, it's not a deadly disease or something, so it's not like cancer. So people, I guess you have to weigh carefully risk and benefit. And the more data we get that show that this treatment is safe and effective, I guess we'll be a little more positive about introducing. So I guess we still have to wait to see the results of studies. And there are many studies now happening all around the world. So we'll have to see, what happens.
I would agree with that completely. In my world, these days, I think we've gotten very good at preventing these scary side effects and then intervening on them early when they do happen. And it's actually the rare patient. In fact, I can think of almost no times I've ever said no to doing a CAR T because of medical comorbidities in lymphoma. We've treated people up to age 88, people with heart conditions, people with neurologic conditions, and people do quite well. It just kind of is a question of, as Dr. Kirou said, what's the risk benefit? If someone is doing well on their current autoimmune treatment, then potentially it's even that is potentially not worth the risk. But especially for young people, and where we can potentially see these very durable remissions that last for a long time, and people with severe disease, I think it's worth taking the swing, and we're able to get people through.
Thank you. Dr. Yamshon, we had this question come in a few times. Can the therapy be used for hairy cell leukemia?
So one of the beautiful things about CAR T is that protein you can choose whatever target that you want to attack. And so CAR T is actually currently in clinical trials for many different kinds of, as we've discussed, autoimmune disease and cancer. And basically the key is finding the right spot that's on the bad cells, but not on the good guys. And so you're not getting what we call off-target effects. To my knowledge, we don't have any clinical trials here in hairy cell leukemia, but my guess is that they probably do exist. And again, like with the right target, I think CAR Ts are being used in all different kinds of things.
Thank you, Dr. Yamshon. Leila, this question is for you. Can you talk us through how do we speak with our physicians or our medical teams about whether we may be eligible to participate in a clinical trial for CAR T cell, or if this may be even an opportunity for lupus treatment?
That's a great question. Thank you so much. I think it doesn't hurt to bring it up and to ask. Again, one of the things I think we've all talked about is eligibility and how a patient is responding to their current treatment, and those are all things that your doctor can talk to you about, or find somebody to refer you to talk to you about.
Thank you, Leila. And I know we're almost at time, so if all our panelists can stay on for 2 minutes, or if you need to go, we totally understand, just to get to a few more of the great questions that are coming in. Do researchers know how autoimmune B cells differ from normal B cells? Perhaps that we can create therapies that kill only the autoimmune H cells. But do we know, do researchers understand how B cells differ from normal?
Right. This is a difficult question. It's hard to pick the autoimmune B cells. So, for example, you can target those cells that express antibodies against ANA or something like that, but we're not there yet. And fortunately, just going through the B cell depletion we eliminate all B cells, and then very quickly all the B cells come back. So the good B cells come back. So I think it's not 100% necessary to do that, but it potentially people do that for other diseases. I think for pemphigus, where they know there is a specific target in the skin that causes the bullous disease, people are doing CAR T for that. So they will be, I guess, done better in the future, more specific. But for now, whatever we have, it works well, it looks like.
And this is a follow-up question to, I think, your talk earlier, your slides, Dr. Kirou. How long did lupus patients stay in remission with some of the studies that you were presenting?
Yeah, so I guess I mentioned briefly before, we have patients up to 2 or 3 years that are staying in remission, but we don't have more, longer data.
And is there an age limit for CAR T trial therapy?
I was the trial that I saw, that I presented, had young patients, and lupus are young usually, but very encouraging to hear Dr. Yamshon say that age is not a major factor anymore as we get better in how we treat. So I would think, that won't be a major issue.
Yeah, I would agree with that. As I said, at our center, we've treated up to age 88, and I know other centers that have treated people into their 90s. And it all comes down to, how bad is the disease that we're treating, and how effective are the current treatments. And so, and do we think that CAR T has a good shot? And if we think that CAR T has a good chance of helping someone, age is not a restriction.
Thank you. And just our last 2 questions. Are there anything that would disqualify you from being able to potentially access this type of treatment? For example, heart issues, lupus nephritis, is there anything to disqualify you?
I would say so. The clinical trials do have inclusion criteria. I would say from a medical standpoint, it's actually like once these treatments are FDA approved, it's actually very rare that we disqualify people for any sort of medical reason. The most common reason is actually those social barriers of needing a caregiver, needing to be within 2 hours of the hospital, needing to, not drive for 8 weeks, et cetera.
Thank you, Dr. Yamshon. Dr. Kirou, did you want to add something?
Yeah, I just want to say, like Dr. Yamshon mentioned, the clinical trials, that's what we're doing now. This is not approved obviously for treating lupus at this point. So the clinical trials have their own criteria, eligibility criteria. So we have to follow what it is there. So I guess they don't want somebody who has end-stage renal disease, they are on dialysis. That won't be a patient that will qualify for this study, for example. And the point is that we need space for improvement. If somebody has active disease and inflammation, yes. If they already have damage, if they have a kidney that needs kidney transplant, then maybe that will be the choice for that patient.
And Dr. Kirou, are there any current therapy trials available at HSS now or in the future?
So we're working on getting one CAR T trial now. Hopefully by the end of the year, we'll be ready.
Thank you. And just to finally wrap up our Q&A portion, how long until we see CAR T being offered as we do some of these other drugs and lupus treatment?
So that's another good question. And I think Dr. Yamshon and Leila spoke about fine-tuning with other things. So perhaps these the bispecific antibodies will be easier to administer, and they're going to be maybe not as good as the CAR T, but very good enough perhaps. So we'll have to see how these evolve, because these are easier to administer. They don't require hospitalization. They may be easier to do. So now and then I guess, so we have to wait for successful trials. When the successful trials happen, then they have to go through FDA to be approved. So it takes several years to do that.
Thank you, Dr. Kirou. Thank you, Leila, and thank you, Dr. Yamshon, who had to leave. As we conclude, a friendly reminder to just please spend a few brief moments completing our program evaluation that has been included right in our chat box. Your feedback really helps us to inform future programs. We will be connecting with our speakers to ensure if they're comfortable with sharing their slides, but there will be a recording available of the talk in a few weeks, and you'll receive an email about that tomorrow, about how to access the recording. We thank you all for joining us for our series of programs for Lupus Awareness Month. We're wrapping up tomorrow with our Lupus 360 panel, so please look out for that information that will be sent to your inbox and to your email. Have a wonderful evening, everyone, and thank you so much for joining us. Happy Lupus Awareness Month, all.